Okay. Dr. Itzaz, are you with us?
Islam, yes, I am here.
Okay. The recording has started. We are already live. So I'm muting myself and you can take over the session from here, if that is okay with you.
Hello, sorry, what you said, Dr. Kamal?
I said that the recording is on and we are already being live streamed. So I'm muting myself and you can take over the session from here, if that is okay. If you're on, all is okay on your end, then.
Yes, it's all right. Thank you. Should we start? Before going to start, if someone and or anyone has the question regarding yesterday's session, so there is a 1 minute for the question and answer for the yesterday's session. No question? If no, then we will proceed. No question? Am I audible?
Yes, sir.
Then no question?
No, sir.
So today we will discuss percutaneous pedicle screw and costotransversectomy and the posterior midline structures. So for this one, you have to know about the idea when we are talking about the open surgery, open standard surgeries. So look at this one. This whole is the picture of the posterior part of the spine, skin, fat, fascia, the huge bulk of the muscle over there in the thoracic spine. When we are doing the posterior standard open surgeries there, we have to go through all these structures, then we will reach as the posterior side, this area. Okay. Comparatively, when we are doing the minimal invasive surgery, either it's a percutaneous, even as a tubal retractor by with the help of endoscopic surgery. So there is no need to retract these eye kind of muscles there. Just we have to put and give a one incision, and then we have to put a retractor. Tubular retractor is over there under the image of the fluoroscopy, then we can reach over there. So this long retraction now are being completely or to some shape, or you can say partially being transferred and transformed to minimal invasive surgery or less reduction surgery over there. Either it is a brain surgery or you can say the spine surgery. So this picture is important when we are doing the open or you can say the minimal invasive surgery. When we talk about percutaneous pedicle screw, is percutaneous is same approach with the, you can say the thoracolumbar is the standard approach for the thoracolumbar is the same approach. Thus there's a trajectory and entry point is different. Otherwise, the same procedure you can do in the lumbar spine. Percutaneous pedicle screw has a lot of importance and a lot of indications are there as same that of the uh, traumatic injury. Most of the time, the traumatic injury is there. Okay, suppose that if we want to get the fixation and single level or multiple level, then we can do easily percutaneous pedicle screw instead of opening the whole spine in the open surgery. So this is the picture. This is, you can see the skin incision. There are two things that are important. You should know that suppose that this is the midline actually, and this is the area of, this is spinous process, and somewhat how if we made, this is the area of pedicle bilaterally, and this is the area where we can give the incision. But it depends upon two things. One, before going to do surgery, you have to do the fluoroscopy to see that what is the level and where we should give the incision. Ideally, when there is a pedicle in the fluoroscopy, you have to give the incision more laterally, lateral to the pedicle. When we see in the patient, the skin incision is given, you can see when in the midline, there is a midline structure, there is a spinous process you can feel. Lateral to midline. Dr. Farula, please mute yourself.
I have muted him.
Thank you. So when you feel your spine yourself, this is very easily landmarks we can see. In the midline, we can see elevation and bony spine in our own spine midline. Lateral to that one, bilaterally, there is a depression. Bilaterally, you can feel the depressions over the lateral to the spinous process. That depression is the area of paraspinal muscles. This is the area of paraspinal muscles. This lateral depression. Or you can say, when we are talking about the musculature, this is the area of paraspinal muscles. That depression actually, this whole is the area of paraspinal. When we talk about the bony spine, that is the area of posterior elements, including the transverse process. Look at here, medially the lamina, and then pedicle and the transverse process. So this depression, when you feel laterally in the mid elevation, after mid elevation, lateral to this one, this depression is the paraspinal muscles. So it means when this depression ends, then again there is a bulge bilaterally. That bulge is because of the thoracic cage and thoracic muscle. That's the huge bulge. You can see and palpate your back as well. And that bulge starts when it means there is a junction of costotransverse, you can say the area. That's the area that where the ribs actually they start. And the musculature is there, the long muscle, the trapezius over there, and the whole fold and the huge muscles of latissimus dorsi. That's why you feel bulge over here, okay, in this area. So the depression, that is the paraspinal muscles, give incision just at the junction of lateral bulge of the thoracic, where the bulge of the thoracic muscles and the depression is over there. Or you can say the lateral to that depression, that we call it the level of, you can say, the end of the paraspinal muscles. So we have to give the incision laterally. More or like the same that you have to give the incision 4 to 4.5 centimeter. But again, it depends upon the patient. Some patients, they are bulky and more muscular than this patient. Then again, the incision will be more lateral. So this anatomical demarcation is very important when you see. Look at this picture when I am going to see here. Then you will be clear. When you see this one, this is midline. This will be the midline. Okay. From here, this midline, can you see this is a little bit depression over there from here to here? That is the area of paraspinal muscles. And then from here to all over there is a bulge. And look at here, this is the depression bilaterally. This depression actually is the area of paraspinal muscles. They're attached to the spine posteriorly. You can give the incision bilaterally here at this site. This is very easy. Look at here. This is the midline. This is the area. And look, this is the area that where we can give the incision, because this is the area of paraspinal muscles. And from here, this is the huge bulge over there because of the thoracic big musculature area. So this is the way that where we can give incision, and we should know about each and the detail of this anatomy. So when we have given the incision is just lateral to image projection of pedicle, one thing. Then skin incision is just lateral to the paraspinal muscle, second thing. Third thing is the junction between the paraspinal muscles and the bulge of the thoracic muscle, like the latissimus dorsi. But all beyond of this one, you have to confirm this level, your whole levels in the fluoroscopy. First, you have confirmed, and we have given these 3 incisions because 3 we have to fix this one. Later on, what happens? It's very important to know for you and for us as well as a neurosurgeon. If we are doing in the thoracic spine percutaneous pedicle screw, the trajectory is different because thoracic spine is a bit different from the lumbar one. You see, when the thoracic spine is there, vertebral body is small. We have discussed that the thoracic spine pedicle is anterior-posteriorly placed somehow. It's not oblique and laterally placed. Look at here. The lumbar vertebrae, they are laterally placed, not obliquely placed, not in the AP line. But somehow the thoracic pedicles, they are vertically, they are AP line placement is there. When we start from the above, they are more in the AP direction. When we come down in the lower thoracic spine, there is a transition, then they became, you can say, the oblique and laterally placed, okay? So that's why on the basis of this anatomy, our screw entry point and trajectory depends. Okay. So after giving, you can say, the incision, we have given the incision bilaterally at all the points, single incisions. You will give single incision at all the points. Now with the help of blunt scissor, you have to dissect the subcutaneous. You have to dissect the fascia, fat, and the muscles all over the muscles. It depends on you. Most of the time, the surgeon says, some says that all the way to the bony spine, when you feel the tip of your scissor that there is some bony structure, then hold that one. But someone says that when you are dissecting the muscles only, then it's enough with the help of retractor, then we can dissect. So there is a blunt dissection. There's less bleeding with the help of the muscles when will be cut down in the lines of there, you can say longitudinally, there is a less type of the bleeding. So you have to go through all the structures, all the superficial and deep structures will be bluntly dissected with the help of scissors. At all, you can say the 6 points. If we are doing 3 levels, you are doing 2 levels, you go to 4 levels, up to you. But all levels will be dissected equally. Look at here, this picture is very important to learn for the learning purpose, to know the trajectory, to know when we will use the fluoroscopy and the C-arm. It's up to you. Mostly the O-arm should be used or the fluoroscopy, but if someone has not the capacity of that one, then we can use the C-arm. This is the superior view of that one. You can see when we are dissecting the body, we can see superiorly. In this is posterior view. When we are doing the screw, we can see posteriorly spine is like that. The spinous process. Okay, this one is the spinous process. Here is the transverse process bilaterally. These are the facet joints. This will be our entry point. Then the junction of pedicle. These are the pedicle, the junction of pedicle and the body. Look at here, these are transverse process. This is the entry point of pedicle. This is the medial portion of the pedicle. The second point. Look, you have to memorize and make this mirror image in your brain, because in the same way we will follow a percutaneous pedicle screw imaging. And then this is the third point, that it means it has been entered into the vertebral body. This is the lateral view. When you see laterally, these are the transverse processes, spinous process, and spinous process. Here will be the facet, superior articular facet, this is the body, this pedicle is there. This is the lateral end of the pedicle, whereas our first image should be there when we reach the Jamshedi needle or cannulated needle. When reach here, it means we will take the first image. These three numbers denote are shown here that you have to take the three images only. If someone is taking fourth one, then it means he or she is giving some extra rays to themselves. Otherwise, there is no need. Second image will be taken when the mid of the pedicle is there, when the medial portion of the pedicle is reached. And third image will be taken when we are crossing the pedicle and entering into the vertebral body. It means we are in the good direction. So look at here. In this way, we have purchased our and put it our school there. Okay. So in this scheme, we will follow this whole scheme in our surgery. We have given the skin incision. And second thing is that you have to follow this clock. Look at this clock. This is the clock. This is the cranial end and the caudal end. And when you are placing this one, the 12 o'clock, 9 o'clock, 3 o'clock, and 6 o'clock. Okay? You have to be clear about this side. And this is the right side of the patient, and this is the left side of the patient. We have dissected subcutaneously and all the way till that the bony structure bilaterally at their own levels. We have put it down bilaterally, the Jamshedi needles or cannulated needle. Cannulated needle, you know very well when it has some hole inside that one. It should be hollow because we have to pass a wire through that needle. That's the called K wire, lateral arm. Okay? When you're putting down this one, our target is lateral boundary of the pedicle. Look at here. This is the pedicle. This is the lateral boundary of pedicle. When you are passing it, take the image, and this will be the image of sun. In the superior side of this slide, you can see X-ray over there. The Jamshedi needle is touching the lateral part of pedicle. Look at here. Can you see? It is
Yes, sir.
visualized to you people? Okay? Bilaterally. On both sides. On the right side, the 3 o'clock. On the left side, 9 o'clock position. The lateral end is there. Look at the previous picture. This one is the first. This is our entry point. This is our entry point first, where we are just entering inside to the pedicle. Okay? Look at here. When it's being entered, we are at the level of lateral boundary of the pedicle. It means we are in the right direction. But pass through the needle or tap the needle further. Then the second thing is that your target is the medial portion of the pedicle. Look at here, bilaterally. This is on the X-ray, same we have targeted and approached the medial portion of, you can say the pedicle is there. But we shouldn't cross this medial portion. This is our limitation and demarcation, not above from this one. It means when we are passing through this one, that means we will damage the normal structures and the nerves, and you can say we will enter inside to the wrong direction to the cord and the canal. So be clear about it. When it is being entered at the level of medial portion of this one, bilaterally, it means we are on right direction. If someone has crossed, just retract and reposition, go back, and with the help of, you can see the ball, small ball insert into the ball means the ball probe inserted this one. Again, you have to see that it has been, it is entered into the canal or wrong structure or not. Okay. The medial portion of the pedicle has been reached. Now what happens? We have to take the left lateral or right lateral, whatever you, up to you. It is not depend on the left and right. It means the lateral image or fluoro of your target or your direction. So in this way, because this has been purchased and the medial direction. Now we'll see, look at here, this is the pedicle. Pedicle medial direction when reached. This is the medial direction, medial part of the pedicle. Look at here. And this was the initial point. When you have touched this medial part, or you have crossed this one, but actually the thing is that when you are touching just the medial part of this one, just tag the filler, because you have to see that you are in the right direction or not. You are about to enter into the vertebral body or not. If not, you are entering vertebral body, it means you are in the wrong direction. Retract your Jamshedi needle or cannulated needle and reposition it. Again, retarget at the medial side of the pedicle. Then tag the filler or image. Then again see it. But look at here, we are in the right direction. Okay, we are in the right direction. When it has been, you can say, the entering into the vertebral body. Look at the previous picture that we have seen. That is the second floor over there. This one. This is the second point. Okay, we are tackling the second lateral floor. About it. The two images on that one, and the same time when we are tackling this one, it will be considered second image. What about third image? Go inside. Go inside. Put the needle further and pass away in the same direction. What direction you are given in the next slide? We will see the direction, what direction and trajectory we are going to do in the thoracic and lumbar. So in the same direction, what direction we have decided, what is the appropriate direction of, you can say, that level, go directed further till that at the mid of vertebral body. Look at here, the needle has reached and about to reach the mid. And we have taken the last floor and the image that our needle has been reached over the mid of the vertebral body. It means now no need to take any third and the fourth image, because now from the vertebral body, nothing else and extra structure where the needle will go. But sometimes we take, but there's no need. When you have reached the mid of the vertebral body in the lateral floor lobe, it means you are in the right direction. Okay. So after touching the mid of this one, what you will do, what happens, we will pass the K wire inside that. That K wire, we will pass that K wire, okay? We will take out that one. There are two school of thoughts. First is that with the help of junction needle, that should be there. Then dilated retractors should be there. Pass the dilated retractor for more dilatation. It's up to you. Dilate all the levels all the way till that you have purchased the vertebral body and posterior elements with the help of Jamshedi needle. First thing. Second thing is that ideal is that one with the help of, because Jamshedi needle is a very hard and solid structure, it will not mold. So with the help of that one, pass the dilators all the way to make the trajectory or the place of pedicle screw. When they become dilated, remove the dilators, and what happens? Put the, you can say, the K wire inside the Jamshedi needle. Remove the Jamshedi needle, but make sure that K wire should be inside that one. After that one, when the K wire over there, what happens? The dilator has been done. With the help of K wire, you have to pass through the cannulated screws. Look at here. Okay. After dilators and this one, pedicle screws, the cannulated pedicle screw should be put down, because we have made the space all the way and K wire is there that will guide us. Look at above the picture that the cannulated pedicle screws are being passed all the way. When they become passed, now it means we have done that one level. If we have done one level, do all the levels in same fashion. 1 level, 2 level, 3 levels, 4 levels bilaterally. If the 3 levels are there, it means we are doing 6 levels, 6 parts, 3 levels on each side. It means 6 pedicle screws should be there. So in the same fashion, you have to do and pass the screws all the way, cannulated screws in this way. But the main thing in that one, this is not the big deal. The main thing is that we should know the trajectory and entry point in the you can say the thoracic spine. When we are dealing the thoracic spine, we divide the thoracic spine entry point and trajectory into 4 parts according to the transition of you can say the vertebra of the thoracic spine from T1 to T12. We divide upper thoracic one, that is the T1 to T3, because it's the transitional change of cervical to thoracic. So we have to see 4 landmarks over there in all thoracic spine, and that 4 landmarks will decide our entry point and trajectory. Look at here. First landmark is superior articular facet. This one. This is the superior articular facet. This is the first landmark. Second landmark is inferior articular facet. Third landmark is the TP, transverse process, but mid of the transverse process, this one, look at here. And the last part is the pars articularis area, that is the ridge of this one. This is the ridge of the pars articularis. So these are the 4 landmarks. When we know about them, our entry point is fit somewhat in the direction and lining over there. Then what to do actually? When we're talking about T1 to T3, we have to make a horizontal line in the mid TP, transverse process. Look at this one. This is the horizontal line. I have to draw right now. Okay, look at here. Sorry. This is the line. That's the transverse process. Mid of the transverse process, a line should be drawn. Look at here. This is the transverse line. Then a line that is vertically just lateral to the midline of superior and inferior articular facet. Look at here, this one. These are the lines that has been drawn. In the T1, T2, 3, the entry point is the intersection between the line that is from the just lateral to the midline of superior and inferior articular facet and the transverse TP line. That intersection, look at here, this will be the entry point in T1, T2, 3. It is exactly that line, look. So in T1, T2, 3, that lines are important. Just lateral to the superior and inferior articular facet, and that transverse line in the mid of the transverse process and the line of intersection there, then we can place that one. This is the entry point. And what will be the screw direction? It's slightly medial and caudally placed. Look at here, this one. This is the lateral view. This is slightly medial and in the caudal direction. And second rule is that is written in the Greenberg and other books. When we talk about, I think what I know and remember, that is the T1, T2, and I think T12. T1, T2, T3, and T12. That is the rule of mid TP. That is the rule of mid TP. What is the mid TP? We have to make a line from here. And this is the transverse process. This is the transverse process. They are saying that there's a rule of TP. This is the second one point. But when you are following this rule of TP, that is the mid of the TP, T1, T2, T3, and 12, then the direction will be angulated, will be more changed. Then you have to go more medially as compared to this one. But when we are following these landmarks, our direction will not change, our trajectory will not change, because already we are at the level of, you can see the same trajectory over there. Again, they are saying that when you are following these kind of, you can say, the mid TP rule over there, it means we have to change the direction. How? For T12, we have to go for the -5, that is laterally, little bit laterally. Then we have to add 2 degree medially when we are going superiorly above. Suppose that if we are going at the 11, for 11 the degree is 0, vertically go downward. When we are going at the level of T10, then add 2 in the 0, that is the 2 degree. Then 9 will be 4 degree. In this way, when we are at the level of T1, it will be 27 degree. Okay, this is the rule of TP. When we are following that rule, that when there is a T1, T2, T3, and T12, then the mid TP is there. When we are following the landmarks, then just screw will be slightly medially and caudal, and just 2 degree as the rule is are there. Okay. So when we are saying at the above middle part of the thoracic spine, that is the T4 to T6, who is written there. So look at here. Now we are going laterally. Look at here. Our line will be the lateral, touching lateral to part of this one, mid of the TP, and the line of intersection will be there. Okay, this line of intersection is there over for T4 to T4 to T6, you can see. And then screw, you will be, you know that it is almost vertical over there, because now the spine has going out from the transition from cervical spine. So that's why at the mid of thoracic spine and just lower above the thoracic spine, the pedicle are more in the epi direction. That's why the screw will be directed vertically. Okay. This is the T7, T29. The entry point is more cranial and caudal compared to this one. We are going more laterally. And this is in this way we are following that TP rule. And just the axillary part. Now look at here. This is the facet joint. Draw a line from the facet joint over there. Then draw a line from this transverse process. At then mid of that one, there will be the line, a horizontal line in the mid TP. This is the transaction line. Then we have to do these two mid of this one. Simply, you can say just lateral part of the lateral facet, superior and inferior, just medial part of the transverse process, that is this portion. Mid of that two landmarks, that will be the entry point for the T7, T29. And the angulation is will be same because it is in MP direction. What we have seen, because the pedicles are now in the epi direction. T10 to 12, these pedicles tend to be more narrower. Who is there? The lecture, it will be more appreciated the degree of the TP angulation. Okay, we have previously told this one that when we are talking this one, when we are doing this one, that the angulation depends on two things. That one thing, that when we are doing the anatomical landmarks, then it will be straightforward to that. But when we are saying the rule of TP, like the for T1, T2, T3, and D12, that the mid TP is rule. And when we follow the mid TP rule, actually, the angulation for thoracic spine is that for T12, you have to go for the -5 degree laterally for T12. because T12 is the junctional area. It means the junctional is going to transform into the lumbar. That's why the little bit lateral projection will be there in T12. That is -5 laterally. When we talk about T11, that will be the 0 degree. And from T11 to upper levels, add 2 degrees medially. This is the direction of, you can say, the trajectory of screws. Okay, so in this direction of the trajectory, you all know. After that, we have 3 levels of that one. Bilaterally, we will pass the cannulated screws, put the cannulated screws bilateral in all the way. After putting down that one, what happens now? We have to pass the rod. We have to put the rod in that one. How we have to put the rod? We have to give a separate small incision just posterior to that one bilaterally. Then we have to put a rod, but put a rod in a rotatory direction. How rotatory direction? Just from outer to inside. But outer to inside how? Because this rod is rigid. How it is that it is flexible and you have to rotate it like this way. And this rotatory direction means rotatory inside the incision, because in this way it will help you to pass through these arch subcutaneous structures easily. When it goes to this direction, then you have to, with the help of Filoro, you have to pass this rod all the way bilaterally. In that, in one direction, in second direction. Bilaterally, you will pass the rod, tie the screws, and get the images. Bilaterally, we have passed the rods, and then you have to suture the skin incision only. No need to go for the subcutaneous and muscular. This is the technique of percutaneous transpedicle screw. Any question regarding that one? Any question?
I don't have a question. I just wanted to add a comment
What
since
we
it
talk
has.
about just screw size. When we talk about the screw size means two things are there. You have to know. One thing is that the length of the screw. When we talk about the standard length of a screw, that is about 35 to 45 mm. But most likely 35 to 40 mm screws are enough. When we talk about the diameter of thoracic spine, it is a bit changed. How? Because you have to see the pedicle of the thoracic spine. It's not same that of the cervical spine or the, you can say, the lumbar spine. It means it is seen and it's been written in the literature that your diameter of this pedicle screw should be 80% of the pedicle size. You have to see the pedicle size, what is there. Most likely is about, you can say, the 4 to 4.5 screws are there, 4 screws are there. But that screw will be 80% of the size of your pedicle. It is the rough idea, you can make that one. But the standard size, that is trajectory up to, it is written that 35 to 45. But the body is small as compared to the lumbar one. Most of the pedicle screws, they are being passed at the range of 35 to 40. It's enough. Start from 35. Yes, Dr. Kamal, you are saying something.
Yeah, I was saying that I do not have a question about the approach. I just wanted to add a comment. I think it's a really good approach when a patient's morbidity postoperatively is a concern, or we are concerned about the long incision and whether it would heal. So regarding that, it's a good approach. But when it comes to young women, young females, then this approach is not a good option until and unless somebody has a navigation. If their OR features a 2D or 3D navigation, then they are fine to do with a percutaneous pedicle screw placement even on a young female. But with the fluoroscopy that we generally use in our setups, percutaneous pedicle screw will provide a lot of radiation exposure to any young female. So I think it would not be the approach of choice in them. But otherwise, it's a good approach in terms of morbidity and in terms of the time of recovery.
Yes, you are right. But my point is that we are giving extra radiations without no need, because I told that there is only 3 points are there where uh, you have to take the image of fluoroscopy, the C arm or what O arm you have. Otherwise, if more than 3 images are being taken, it means either we don't have the confidence, either we don't know have the landmarks, anatomical landmarks, are not aware of the approach. This is up to us and on the surgeon, that how confident, how experienced, how competent, how they have gone through all these approaches. There's more than 3 images. I don't think so. There's need of that one.
But wouldn't you agree that since it's a minimal invasive approach, the learning curve is slightly steep in comparison with the open approaches? So when a resident or a new consultant is learning these minimal invasive approaches, they are obviously going to need slightly more images. So that's my only concern, and probably that is why I have not liked this approach as a general solution. Until and unless someone's OR is featured with better gadgets, like somebody mentioned robotic navigation. Yes, that's a good option.
Yes.
If there's someone
Not
has
many.
2D or 3D navigation, that's a brilliant option. But we don't have them. We operate on fluoroscopy.
Yes. So any question about this percutaneous? No? Any question? Should you proceed further?
So nowadays that robotic navigation came, in the robots, they will direct the direction of the pedicle and the robot directly enter the screw in a high precision. There
Yes,
is
not all centers, because in Pakistan, how many centers are there which are doing? I think only one center now in the Gambut, and the other centers I don't know about that one. In the world, there is a few centers over there, and the robot has lot of cost over there. So not all centers they you can say they afford the robot. If there is a robotic spine, that is good, ideal, because we will be free from these all radiations. Yes, you are right. Anyone else who has the question? No? Anyone else who want to add some points in this one, percutaneous pedicle screw? He and she is welcome. No? Thank you. So let's see the costotransversectomy. How many of you are well aware of about the costotransversectomy? So what are the indications of costotransversectomy? Anyone? What are the indications of costotransversectomy? Aneurysmal bone cyst of the vertebral body, lateral disc pathology. Yes, you are right. You cannot do the central midline disc in the costotransversectomy. You can do, but there should be a soft disc. Soft disc, mostly the ideal, that's the lateral one. And if the medial one is there, it feels some difficulty over there. But you can do in the tumor to the anterior and lateral side is there. We can do in the TB spine, we can take a biopsy through this one. We can do with the help of any, you can say the bony tumor, we can do this one. Corpectomy, some portion of corpectomy over there, we can do with the help of costotransversectomy. So these are some indications. Previously, it was thought that is the only approach, and this is the approach only for the TB spine, but now it has been changed. For some midline soft structures can be taken out through this one. And actually, it is a costotransversectomy. After all other approach that are related to this direction, they are, to me, they are you can say the variants of costotransversectomy, nothing else. They are variants of costotransversectomy. You will see that how they are variants of the costotransversectomy. So let's start. So this is the picture where is the targeted area. When we talk about the costotransversectomy, it means we have to take out the rib, this one, some portion of rib. We have to take out the transverse process, some portion of the pedicle, some portion of the vertebral body. This portion we can take out, or if not taking out, just entering through here and take out the disc over there, that is the lateral disc. Okay, so this is our trajectory for the posterolateral. As this is the posterolateral approach. Previously we have discussed there are three posterolateral approach. That is the costotransversectomy, and second is the transpedicular approach. Extra cavitary approach is that. Out of them, this is the our, you can say, yes, you are right, 5 centimeter of the graft. Okay, this is our target in the costro. But look at this picture. This is costotransversectomy, this one. This is the costotransversectomy. But what about this one? What is this approach? And what is this approach? Yes. We know that this is the costotransversectomy, but we have another two approaches similar to that one, costo, just the trajectory is being changed. Extended costo? No, costo extended is not. Only the standard costotransversectomy is there. There's no one extended. If it is extended, that will be converted to this approach. That is, you can say the extended one, but it is not extended costro. If you are not extending, you are limiting over here, this is this approach. Okay. The purpose of mentioning this one, actually, you should be well aware of these all kind of trajectories, because these are, to somehow they are similar, just the direction is being changed. Look at here, this is the costo, and look at the above diagram on the left upper side. We'll start from the midline. This L shows the midline approach. From L to this area, when we have this area, the region here, the midline approach, we can access this whole area, okay? This whole area. We can get access through the midline approach. When we are going just lateral to this one, this approach, I am making with the help of other one. This one, it is in which direction? This is pedicle. We are targeting the pedicle. That is called the transpedicular approach. So this is the transpedicular approach. We are targeting the pedicle, then entering to the vertebral body. Just lateral to this one, when we are more laterally than this one, this approach, that is targeting not only the pedicle, this is targeting this portion and this area and this area. This is called, this area whole is called the costotransversectomy. This is called CT. Okay, look at here. When we are going more lateral to this one, this is what costotransversectomy. Look at here. This rib has been removed, have to be removed. This spinous process should be removed. This pedicle should be removed. This part of the vertebral body should be removed. When we are going more lateral to this one, we know more that one, but there is extra cavitary approach. We are not touching, you can say we have to go posterior to this all part, posterior to the neurovascular bundle. Then we are going at this side. That is called the lateral extra cavitary approach. Okay, look at here. This whole portion will be removed with the help of. That is called the lateral extra cavitary approach. So look at this picture. When we are going more lateral and this one, this is which approach? Anyone who can tell me? When we are doing this approach, this will be which one?
Your audio is unclear, Dr. Itzas. I think you have moved away
This
from the
picture.
laptop.
Now it's clear?
Yeah, it is now.
Sorry?
Yes, it is now.
I have make this one with the help of orange. When we are from midline posteriorly going laterally and then going anteriorly, these are the approaches. So this is which approach?
Thoracotomy approach, sir.
Yes.
Thoracotomy you can go. Thoracotomy you can go, sir.
Excellent. 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 This is thoracotomy. What we have discussed yesterday, the transthoracic approach when we are doing, we will exactly reach this area. So these are the approaches and these are the trajectories that we should know very well regarding all these things. When we are talking about the posterolateral approaches, all posterolateral approaches, to me, these are the variants of costotransversectomy. Then there's a limited approach over there, only limited to the pedicle, that is a transpedicular. More extended to that one, that is the lateral extracavitary approach. Okay, so you have to be 5 minutes lagi. This is the prone position. It's up to you. There are two positions that are important. One is the prone position and second is the 30-degree oblique position. 30-degree oblique position and second is the prone position. It's up to you which surgeon is comfortable in which position. Prone position, usually most of the surgeons, they are comfortable in the prone position. But 30-degree oblique, there is a visualization as compared to that when it's good and there is a gravity, so there is a less chances that the space will be clear. There will be the in regard of the bleeding. Okay. And when we are giving the prone position to the costotransversectomy, there are two types of incision that is being given. One incision, that is the midline incision. Why midline incision is being given? Anyone?
Less bleeding.
Okay, less bleeding. Anything else? This is the midline incision that will be given in that fashion. And there will be some lateral deviation of the incision when you are giving midline towards the ipsilateral side and towards the pathology side. And second incision that is being given about 5 to 6 centimeter, and some say that 7 centimeter lateral to the midline. That is this incision. You have to give, what is being done? This is the midline. Go, it's 5 to minimum 5 centimeter. When the patient is more bulky, up to you have to go through the 7 centimeter lateral from the midline. And second is the paramedian incision. You have to go 2 level above, 2 level below, and lateral direction incision like this. Okay, when you give incision, you have to laterally retract this skin flap, and then we'll up to the level of subcutaneous fat and muscles. These are two types of incision. This is ideal incision of costotransversectomy, that is 5 to 7 centimeter lateral to midline. Ideal because it directly goes to the level of that when the joints between the transverse process and the ribs. That's why. And second, midline incision in this sense, because when suppose for somehow when we are going to this level and it's very difficult to do the costotransversectomy, then there will be the limitation of costotransversectomy. We cannot approach. But with the help of midline incision, we can retract all the way and alternate midline and lateral approach we can do. That is called also we can do the transpedicular approach. So midline has this access. We can remove the lamina as well. We can remove the spinous processes as well. So it has a lot of corridors and additional alternate operatively when you feel difficulty in costotransversectomy in getting reduction of the muscles and approach anatomy, then we can do alternate to that one, that we can remove the lamina and that will be modified, you can say, operative thing. Okay, in this one you can do the incision. These are two incision straps. After giving the incision, you have to be very clear about the musculatures, because the main thing till that the bone is the musculature in the thoracic spine, you know very well. Okay, I'm not going into the detail of the musculatures. So look at here, the superficial intermediate limb muscles. Initially, you will see the trapezius muscle, then latissimus dorsi muscle, then medially superficial and the intermediate rhomboid minor major muscle on the superior side, and the lower side you will see the muscles of the paraspinal muscle. That is what you know. Okay, the previous picture when we have seen this one, look at this picture. No, I have forgotten, I think, to put that picture. Okay, yes, this one. This is the normal level and this is the level of costosectomy we will do. When you will go from here to downward, you should know these all muscles. Okay, this is short portion that is medially, that is the trapezius muscle. That is huge muscle, this one from start to the midline and going laterally all over there. It hugs the cage laterally and anteriorly, the latissimus dorsi muscles. And this is the anterior side of the muscle going well too deep over there. These are the paraspinalis muscles. This is rhomboid, part of the rhomboid muscles over there. So when we are cutting down these things, you should know all these musculatures importantly. If you are not knowing the names of this one, yesterday we have seen that we should know the, you can say, the superficial, intermediate, and deep layers. Okay, after giving the incision, whatever you are comfortable, more the ideal incision is the paramedian if you are giving. Dissection is being done. You have to dissect it one subperiostally along the posterior aspect of the ribs. That is there. All the muscle we will dissect it. And at the level of anterior side of the vertebral body, exposure should be adequate. Exposure should be more than 5 centimeter. If you will have the exposure more than 5 centimeter, then it will be easy for us to cut down the rib for 5 centimeter. Okay, because if we will less expose this one, then we will not cut down this to this one. Look at here, we have cutted all the muscles over there. We have exposed this one. We have retracted this muscles laterally, and exposure is more than 5 centimeter. This is our targeted area. This is our targeted area. This one is target area. This is 5 centimeter from the head of the rib of that one. That is 5 centimeter. We have to expose more at the 7 centimeter. Okay. Circumferentially and periosteally, you have to dissect this muscle at the level of ribs, because it gives two things. One, the bleeding will be less and your anatomy will be clear. Otherwise, when there will be the rough dissection, not subperiosteally, then it will be very difficult to identify the structures and the bleeding will be more as compared to this one. Okay, when we are dissecting this one, and then with the help of retractor, that is called the Cobb retractor, manually we have to retract that muscles laterally, and we have to insert one when there is a self-returning retractor there on the contralateral side, then it will be easy for us to see. When we have approached this one, we have resected this whole muscle, dissected the muscle over there, then see the picture over there. Now the rib is clear, transverse process is clear, these all structures should be clear, and with the help of periosteum, you have to dissect this one, the rib, transverse process, part of the pedicle, and this lateral portion and the body. Okay. When before going to the medial side over there, posterior side to this one, from posterior to anterior side to this one, what happens actually, you have to clear this level, and there are two ligaments over there. One ligament that is attached with the help of tubercle to the transverse process. Yesterday we have discussed this ligament. Look at here, this ligament that is called the costotransverse ligament. You have to dissect this ligament or cut down this ligament. When you will cut down, you will go more medially. Look at this picture over there. This is the head of the, you can say, the rib. It is attached bilaterally above and lower with the help of demifascists to the vertebral body, anterior part of the vertebral body. And it is attached with the joint, and that joint is strengthened with the help of radial ligament. Look at this one. This is the radial ligament. So there are two important ligaments are there. The costotransverse ligament and the radial ligament. Cut down this costotransverse ligament and this radial ligament. But the radial ligament will be difficult to cut down because we have to go more posteriorly as compared to anteriorly if you are going there. When you will cut down this one, cut down the rib from there at the 5 centimeter. With the help of subperiosteum, dissect this rib, but take care of the neurovascular structure over there posteriorly. That is the neurovascular structure. Okay, look at here, this here. Till that, subperiosteum till that head. When you will go till that head, now it will be easy for you to see the posterior part that is called the radial ligament. Cut down the radial ligament and remove this rib. When the rib is being removed, now this will be the picture. We have removed this rib. Look at here, the ligaments are being cut down and dissected down. The rib has been removed. When the rib will be removed, the free rib is then you can remove easily, and you can keep that rib if you need for the grafting for purpose of anything. But there's no need most likely when you are doing the single rib. After doing this one, we have seen this area, whatever, because still there is a portion that is called the transverse process. That's called the pedicle. There's a portion of the vertebral body. Expose the lateral vertebral body and subperiosteally. But there is a one thing that now you have to do. What thing that and step you have to do now, because you are at the level of, you can say, the vertebral body now, rib has been cut down. What thing you have to do now? Anyone? I didn't mention here. Where you are going anteriorly approaching the vertebral body, after cutting down the rib, what thing you have to do? Anyone who has the idea? No? You have cut to the pleura. It's the same fashion that of the we have done in the transthoracic approach anterolaterally. You have to cut down the pleura. After cutting down, just retract the laterally as that of the in the same fashion as that of, you can say, the transthoracic approach. Now it will be easy for you to see all these structures, all these levels. Okay, the rib will be cut down before the pleura. After cutting down, when you're going medially approaching this one, now you have to cut down the pleura. After pleural cut down, giving the incision, retract that one, and you have to follow the same tactics and instruction to the anesthetist. Then you have to reach this portion. When you are reaching this portion, subperiosteally dissect this all portion. Now you have to, with the help of, even you have the drill, I have marked myself this level. This portion has been marked. Now this is remaining portion. Mostly the lamina is being not disturbed. When going midline, the lamina can be dissected, but the portion of transverse process, pedicle, and this portion. Look at here, I have marked this portion in this way. This whole portion now is remaining this portion. Okay. Then you have to, with the help of drill, ideally with the help of drill, not is able gently and very carefully with the help of bone nibbler or punch, you have to remove this bone, this area. Look at here. We have removed this bone, this whole area. Now we are at the level of this level. This is the lateral side of this is the area of the lateral disc. We can approach through here in the midline soft disc. We can approach at the level of lateral side in the body of this one. Whatever the pathology, suppose that we are doing the disc, with the help of this one, we will pass through and discectomy will be done, annulus will be incised, and discectomy will be done, and you will do all the things in this way. Okay, drill or remove transverse process pedicle and portion of vertebral body will have the help of this one, whatever the gadgets you have. So this is the technique of, you can say, the costotransversectomy. When whatever the pathology you have done, then now if you see that there is an instability over there, then you can place a cage or you can place a graft over there. But usually in single level approach, they are you can say there is no need to place any graft or cage, anything instrumentation over there. And second thing is that there is a chance of after going all through this, you have to see about you can say the pneumothorax. Okay, most likely over there you have to put the saline and ask the anesthetist to do the Valsalva and see the leakage of any kind of air there. Then you have to confirm, because the most common complication in this one complication is the vascular, and one complication is the related to the pneumothorax. Vascular complication, sometimes the radial artery is being damaged, most common thing. And sometimes when there is artery of Adamco is over there, because most of the costotransversectomy is going to be, you have to do on the right side. There are two reasons. One main reason is because of the, you can say, the arterial supply, that is the artery of Adamco is 80% to 90% the artery of Adamco is, they arise from the left side. And second thing is that due to radial injury, there is a vascular injury, the bleeding can be more. And when these two become injured and damaged, there is a chance of ischemia to the spinal cord, and the patient can have post-auditory deficit. Otherwise, there is an excellent approach aside from the, you can say, the complication of pneumothorax and vascular injury. Okay. So this is about all about the costotransversectomy. So the extra cavity approach will be in same fashion. We will discuss inshallah in the next week. In a brief review will be there of these all approaches. But if we know the costotransversectomy, then it will be easy for us to do the transpedicular, you can say, the extra cavity approach. Okay, any question up to in this one? These two approaches, percutaneous pedicle screw, or you can say the costotransversectomy. No? Dr. Kamal, are you there?
Yes, I am. I was waiting for you to finish. I didn't want to interrupt again. So I was waiting for you to
I am
finish.
finished.
Yes, we did go over the time, but I wanted you to be done with at least these two approaches so that, we can see
Yes.
if we want to do the posterior midline approach. I think it's a relatively easy to understand approach. If you're only discussing posterior midline, laminectomy and everything, it would not need an individual session in itself. So
No,
maybe we can
not
discuss.
midline we will not do. That's why
Yeah.
I choose percutaneous pedicle screw. If we are going to open pedicle screw, then it will be same midline. The trajectory will be same, just we have to open the midline approach. The incision will be midline, we have to open the all midline structures. The standard midline approach will not be done right now because the pedicle screw has been done. An open midline approach, pedicle screw trajectory and position will be same that of the percutaneous. So I think there is no need to revise the midline approach. What you say?
Yeah, I think it works fine. Does anyone have any questions or any feedback? Because it looks like we would be ending the dorsal session as well. Nobody has any questions. Either you people are getting every single thing, or you are not getting much out of these sessions. Because I'm as amused at how nobody has any questions. But that's okay. If you have any questions or think of a question after the session, then you can always leave it on the WhatsApp group. Otherwise, that's a wrap for today's session. Dr. Itzal, thank you so much for taking out so much time this week and the last
Thank
week
you.
as well. And we are wrapping up today's session, inshallah. I'll put up the link as soon as I can.
Yes, someone says transpedicular approach, we can go midline. Yes, you are right. In transpedicular, we can go from the midline because it will be easy. You can go midline to the by transpedicular approach or transpedicular approach.
I think we can do
Okay,
a
thank you,
very
Dr. Kamal. Thank you all.
Yeah, Dr. Itzas, I think we can do a very short and a rapid review session on scoliosis and not cover it in detail, like too much detail, but we can go over it briefly. Let me know afterwards what you think about it. I think
Okay, inshallah,
scoliosis
and
is a
next week we will go.
significant pain point.
Yes, yes.
Thank you so much, everyone. Thank you for
Thank you
joining.
very much.
This is a wrap.